Good evening, everyone. There's a shlok in Sanskrit. Nasti vidya samo bandhu nasti vidya sama suhirate. So, carrying this light of knowledge, we are in third week of Gurukul of the month of April. So, I welcome everyone here on this academic tour. I'd like to welcome our honorary president, ma'am, of AOP Gujarat, Dr. Jhankhana Sanghavi, ma'am. Ma'am, kindly give us visionary words on this program today.
Thank you, Dr. Lata. Good evening and welcome everyone. I welcome today's expert speaker, Dr. Gupta sir, the coordinator, Dr. Lata sir, treasurer, PRASHANT KARIYA, and Central AOP Gujarat, Dr. Manish Mehta, and all delegates, and I welcome all dignitaries. Not taking much of your time, we are excited to listen our expert talk, and we are vigorously waiting for Dr. Prashant's quiz. So not taking much of your time, and just we are waiting for enrich our knowledge with the expert talk and quiz. So over to Lata, please.
Thank you, ma'am, for your kind words. We'll miss today Dr. Yogesh Parikh sir and Dr. Nehal ma'am. They are busy with their commitments. So, first of all, I'd like to introduce our expert for today. He's Dr. Naveen Gupta, sir. He's a consultant at Madhukar Rainbow Hospital, New Delhi. And his talk is on hypoxia, respiratory failure in neonates. It's a very important topic. Welcome, sir, and over to you.
Thank you. Thank you. First of all, a heartfelt thanks for giving me. Am I audible?
Yes, sir.
Yes,
sir.
So, first of all, it's an honor and privilege to be on part of this platform, and thank you very much, the Gujarat team, Dr. Nehal, and all of you for inviting me and be a part of this meeting. And as I am seeing in the WhatsApp group, your e-Gurukul meeting, the levels are quite good, very nice. So, in the next half an hour or so, we are going to talk upon a topic which is hypoxemic respiratory failure in the newborns. Many of you, when you are practicing neonatology, you have encountered the situations in which, suppose the child is not maintaining on conventional ventilation, what to do? What are the next steps? So that is what it will cover. It will not cover about the basics. It will cover the baby who is desaturating and whom we are not understanding that what to do. And a major chunk of that is PPHN. So that's why you are seeing the title as persistent pulmonary hypertension of the newborn. Let's start with the case scenario. A term newborn, day 1 of life, and the baby is severely hypoxemic. Saturation is 75% despite 100% FiO2. Blood pressure is falling. So we don't know whether we are dealing with a lung disease or heart disease or circulatory collapse. So all what we know is that this child is not maintaining oxygenation, not maintaining saturation. We don't know what to do. So whenever such a child is there, this child is in hypoxemic respiratory failure. The definitions may vary. Somebody may say that on 100% FiO2, if the PO2 is less than 40, then you label it. However, broadly, if you have a newborn who is not maintaining saturations on highest setting on conventional ventilation, that baby falls into the category of hypoxemic respiratory failure. And mind you, whenever you are taking care of such a child, you have to take 3 corners of the triangle and manage the baby from all the 3 aspects. The first aspect is the lung disease. So this is the priority. As we understand that ventilation is the single most important step in the neonatal resuscitation. Similarly, ventilation comes as TABC when we are managing a desaturating baby. Temperature, then airway, then breathing, then circulation. So the airway and breathing, which is ventilation, that is topmost priority. The second is taking care of the circulation, and circulation means here the systemic circulation. So at the same time, it's our duty to manage the baby in such a way that oxygen is being supplied to the cells and there is no lactic acidosis, the aerobic circulation, it goes on. And the third pillar is taking care of the pulmonary circulation. Many of these babies, whether that is inherent or whether that is secondary to hypoxemia, there is pulmonary vasoconstriction. And when there is pulmonary vasoconstriction, no matter unless and until we take care of this arm, we cannot treat that child. So sometimes when the baby, we are in clinical crisis and we don't understand whether it's a respiratory or circulatory failure, the respiratory failure signs are refractory cyanosis, extremely tachypneic, means the baby will have respiratory distress. You for the silver one and the silver four, depending upon whether you are dealing with a term child or preterm child, and your baby will be needing high oxygenation. And OI, because many of you will be the fellows here, so I will just be basic. Oxygenation index form of that severity. What is oxygenation index? It is the product of mean airway pressure multiplied by FiO2 divided by PaO2. That means when it will be high, when your child is requiring high mean airway pressure on the ventilator, and mean airway pressure is derived from PIP, PEEP, and those parameters. When it is high, when your child is requiring high FiO2 needs, and at the same time your PaO2 is either low or to maintain the PaO2 in the normal range. And circulatory failure signs like circulation failure signs are when your blood pressure will start falling, when you have a poor capillary refill, that means your capillary refill time is prolonged, maybe more than 5 seconds. Because of the rising lactate, the acidosis in your blood gas, you will start seeing the acidosis, and there is a rising lactate. And that may signify that there is right to left shunting, which is happening, which is bypassing the lung. What does this statement means? This statement means that normally what happens is that blood comes to the right side of the from the body to the RA, SVC, IVC. From this right side, it goes to the lungs. In the lungs, it gets oxygenated, and then it is returned to the left side. And from the left side, it is supplied to the body. This is the normal circulation. However, due to some scenario in which, let's say, there is a pulmonary vascular constriction, means the blood does not go, much of the blood does not go to the lungs, and it is shunted away either through a PDA or through the foramen ovale. Like the blood, deoxygenated blood comes to the right side and it directly goes to the left side. So this means that right to left shunting means from the right side of the heart to the left side of the heart, there is shunting happening, which is bypassing the lungs. The blood does not go to the lungs. So that is one more sign of the circulatory failure. And this is the triad I was talking of. Take care of the lung disease. Both the low and high volume lungs are bad. So optimize the lung at FRC. We will discuss this concept of FRC. Take care of the pulmonary vascular bed and take care of the cardiac cause. So what is the pathophysiology of pulmonary and systemic circulation? So normally, so let's start with the definition of PPHN. What is the full form of PPHN? Persistent pulmonary hypertension of the newborn. That means persistent. Persistent means there was initially, it was already there. So in fetal life, if I tell you that how it is happening in the fetal life, that in fetal life, the lungs are not taking part in gas exchange. When the lungs are not taking part in gas exchange, then the pulmonary vascular resistance is high there. If the pulmonary vascular resistance is high, normally, so in fetal life, it is high. Normally, what happens when the baby comes after birth, the baby cries, the air goes into the alveoli, there is oxygen in the alveoli, the pulmonary vasculature, it relaxes in response to the oxygen, and the blood starts going towards the lung, and the lung becomes the site of gas exchange. And before birth, if somebody asks you what is the site of gas exchange, that is the placenta. So in some babies, when this transition does not happen, this transition means the pulmonary pressure, which was high inside the fetal circulation, does not fall after the fetal circulation, and they persist to be high. So that condition is called the persistent pulmonary hypertension of the newborn. And what is the clinical hallmark is the differential cyanosis. Differential cyanosis means that you put pulse oximeter on two sides. What are the two sides? One side is the right hand, and the second side is any of the foot. And you see a SpO2 difference of more than 10%. So that is what is called as a differential cyanosis. Remember, so one message here should be whenever you are dealing with any sick child, so you should place the pulse oximeter at two sides, because if there is a differential oxygenation and differential cyanosis is, then it will confirm the right to left shunting happening at the level of PDA. So always place the two pulse oximeters at two different sites. Remember, this is as a message. Okay. So the saturation difference is more than 5 to 10%. So basically, when we talk about the etiology, why knowing the etiology is important is because if you know the etiology, you can think about how to manage that child. So etiology of this PPHN remains for the three conditions. One is the maladaptation. Maladaptation means due to the anatomy is normal, means pulmonary vasculature is normal, but there is abnormal vasoconstriction because of hypoxemia, or less oxygen is a potent pulmonary vasoconstrictor because of acidosis. So how does that happen? Secondary to the meconium aspiration, which is a very, very common cause. You will say that the baby is born with meconium indica, baby didn't die after birth. So you will think that there is a meconium aspiration. And secondary to that, there is PPHN. So this is the commonest scenario. Second is any form of RDS. Remember, anything which is leading to hypoxemia will lead to PPHN. So sepsis can also lead. The second is the maldevelopment. What does it mean? It means that the vasculature was okay initially, but it has remodeled now. What is the remodeling happen? This media, this muscularis media has thickened. This thing has thickened. So thickened media is there. What are the examples? Like in asphyxia, idiopathic, black lung disease, chronic hypoxemia. You are dealing with the IUGR child, and in utero, because of the placental insufficiency, there is a chronic hypoxemic state. NSAID. When do we give NSAID to the mother? If we give NSAID to the mother, when the mother is having polyhydramnios. So if the mother is having polyhydramnios, maybe secondary to Bartter syndrome or anything, and you give the NSAID, that leads to premature closure of the ductus. And if the ductus gets closed inside the mother's womb, so then there is a disaster, because there will be blood which is going to the lungs. Lungs are not the site of gas exchange inside the mother's womb. That leads to remodeling of the pulmonary vasculature. And the third condition is the underdevelopment. Underdevelopment means, let's say there is a case of pulmonary hypoplasia, or there is a case of congenital diaphragmatic hernia. As we understand that in congenital diaphragmatic hernia, the bowels, they ascend into the thorax and the lung does not develop there. When the alveoli does not develop, the vasculature which is outside the alveoli, it also does not develop. So there is a pulmonary vascular hypoplasia. So this is very, very important. So if the pulmonary vasculature has not developed, no matter you give nitric oxide, you give sildenafil, it is not going to work. Any pulmonary vasodilator will work best in this scenario when there is a maladaptation because secondary to hypoxemia, or there is maldevelopment also, they will work to some extent. However, in underdevelopment, they are not going to act. So when we talk about the causes, so broadly you can remember this is a beautiful slide from Dr. Satyan Lakshman Rinsunna. He's a master. So he has given the mnemonic master: meconium aspiration, asphyxia, sepsis, TTN, effusions, and respiratory distress. And the drastic is the another consequence of the congenital. So he has given PPHN is a master of disguise, and if not treated can be associated with drastic consequences. Drastic stands for diaphragmatic hernia, respiratory anomalies, alveolar capillary dysplasia, surfactant protein defects, trisomy. So in broadly, you can understand that any form of hypoxemia will lead to PPHN. Fun. So you correct the hypoxia, second is any form of underdevelopment will lead to PPHN, that is the congenital anomalies, right? And the third is the black lung PPHN. So when we talk about meconium aspiration, I may skip this, but we understand that the etiology depends upon that how the meconium is obstructed. Meconium is fully obstructed. If the meconium is fully obstructed here, then there will be collapsed alveolus. If the meconium has bivalve phenomena is meconium is obstructed halfway. The air can go inside, but it cannot go outside. So that is the air trapping or the bivalve effect. And also there is a chemical pneumonitis secondary to the reaction by the meconium. mechanical obstruction, chemical pneumonitis, and then an inflammatory cascade starts. And remember, severe PPHN occurs in 39% of the cooled MAS infant. So for the time being, I will just skip these slides. The second thing in PPHN is knowing that targeting the pathway. So there are three pathways. One pathway is CAMP pathway, one is the CGMP pathway. So I will do not get disheartened by this messy slide. Just we concentrate on small things. So
Excuse
CGMP,
me,
you remember
Naveen sir.
that CGMP? Yeah.
Naveen sir, excuse
Yes.
me.
Yes.
Your
Yes.
slides are running late than your speech. That's a lag between your words and the slide. You are getting my
Oh.
point?
Oh.
हाँ हाँ आप जब
Yeah.
स्टार्ट
Yeah.
कर रहे
Yeah.
हो ना
I'm
तब वो
getting your
स्लाइड्स नहीं
point.
आया होता है या हाँ so just थोड़ा सा अगर हो सके तो could be okay. Sorry for disturbing you but I got this thing.
No problem. This was very important. Thank you for telling me. Now, is it the PPH and pathogen slide is coming?
Yes sir. Yes it's coming. Targeting the pathway.
Okay.
That's
Okay.
right.
Now I will.
Yeah.
Yeah. I will just check one more time after the next slide, and then so that we will do this. Okay. So CGMP is a pulmonary vasodilator. Just remember this. Similarly, the CAMP is a pulmonary vasodilator. Means suppose we are dealing with the case of PPHN in which there is pulmonary vasoconstriction, we have to enhance both these things. So how does CGMP is produced normally? In the endothelial cell, the L-arginine produces INO, and in the presence of endothelium nitric oxide synthetase, this nitric oxide goes to the muscle, right? The smooth muscle. And then in the presence of soluble guanylate cyclase, the GTP is converted into CGMP. So just focus on this CGMP. I will just label it as red if you say orange, let's say. Right? Similarly, here the prostacyclin leads to increased production of CMP. So nitric oxide is important because it leads to increased production of CGMP. Prostacyclin is important because CAMP increases. Now both the CGMP and CAMP are being degraded. Let's look at CGMP. It is being degraded in the presence of PDE5, phosphodiesterase 5 enzyme. What inhibits this enzyme is sildenafil. So again, so if the sildenafil inhibits the degradation of CGMP to GMP, so that means it will also increase the level of CGMP, right? Because sildenafil is an inhibitor of PDE5, phosphodiesterase 5. Similarly, here the milrinone is an inhibitor of phosphodiesterase 3, and phosphodiesterase 3 was degrading the CAMP to AMP. So basically, if we give prostacyclin, we increase CAMP, baby will become better. If we give milrinone, we increase CAMP, baby will become better. In this pathway, if we give nitric oxide, the baby will become better because CGMP is more. If we give sildenafil, the CGMP is more and the baby will get better. Entirely different way. There are two ETA and ETB. ETA is a potent vasoconstrictor. So something which blocks ETA, that is the bosentan. So bosentan blocks the ET receptor and it improves it is again a pulmonary vasodilator. Remember, these will be the working on prostacyclin, milrinone, bosentan, sildenafil, nitric oxide. Okay, respiratory circulatory. I told you that the preductal SpO2 and the postductal SpO2, if there is a difference of more than 5 to 10%, and remember, put the pulse oximeter at one here, and one here, the right hand side. Yeah, he has written preductal right hand should be this side. Okay. And labile
Still there
hypoxemia.
is a
What is
lag.
labile
Sorry sir.
hypoxemia?
Excuse me sir. Sir again
Again
lag.
lag.
It's stuck. Yeah, it's stuck on PPH and targeting the pathway slide. So that slide is showing.
Okay, then I will. Yeah, then what I will do is I will just leave the meeting and join again because I do not know. It should not happen. The network is
Yeah.
okay because I do not know why this lag is happening. I have even switched off my video. Can I do that? I will just leave and rejoin.
Yeah,
Is it
that need to
now clinical hallmarks?
clinical hallmark.
No,
Yeah,
now
it's now coming.
Yes.
okay.
Yeah, now it has changed.
Okay. Sure.
Your
Labile
voice is also
hypoxemia
cutting.
means
cutting midway. Your voice is also getting disturbed midway sometimes.
Oh
So
my God.
I think some
Okay, let
issue
me
with the
change.
network.
No, no, no. Let me change my location. Sometimes there is
Yeah.
a problem with the network. There is actually it's
Uh,
little windy outside. Huh. So the
okay.
clinical. So now is my voice better?
Yes, sir.
Okay.
Definitely.
Better,
So
better.
there is, yeah, the labile hypoxemia is also a hallmark of PPHN. What does it mean is that the baby suddenly desaturates. The baby is doing okay, and suddenly you are taking rounds and you are started discussing about the baby, and the baby desaturates. Or suppose there is the light is suddenly it's a bright light. So that's why we say that cover the ears, cover the eyes, try to ventilate the baby or try to discuss about these babies outside the place where the baby is there, and keep the baby in a solitary or the isolated position. Is the has the slide changed now to respiratory and circulatory signs?
Yes,
Sorry.
sir.
Yes, sir. Yes, sir.
Yes, sir.
Yes, sir.
Okay,
Yes,
okay.
yes.
So circulatory signs we have discussed. I will just go to the pointed things. Okay, so this is again a thing that in PPHN whether we should give fluids or not. Ideally speaking, you should give fluid in a baby who is in shock when there is a clear-cut history of the blood or the fluid loss. Like day one, you are dealing with a baby in the labor room. There is abruptio placentae. You understand that from the placenta there may be blood loss, or there is a cord ligature has slipped. Otherwise, in babies with asphyxia, preterm babies on day one of life, usually it's a cardiogenic shock because the immature myocardium is unable to cope up against a high systemic vascular resistance. Similarly, in PPHN, do not go for excessive fluid. If you want to give for one bolus, that is okay. That also should be 10 ml per kilo of normal saline over 30 to 60 minutes. But try to understand the etiology, try to understand the cause. If you don't have a clear-cut history, so do not push in fluids. So hypotension in PPHN is a pump failure. Pump failure means cardiac mass is not a or the tone problem, means the vasculature tone is less, but not an empty tank. So remember that. And there is mechanical harm because if we keep on giving fluid, remember the RV is failing in PPHN because there is a RV dysfunction. Because of the increased pulmonary vasculature pressure, the RV cannot pump the blood into the lungs. So there is a pulmonary vascular resistance is high. So RV is failing, and if you give more fluid, the RV will fail more. Fluid accumulation also destroys lung mechanics and the gas exchange, and your hypoxemia may worsen. Okay. So any targeted analysis only, and your echocardiography will be a help. I think role of echocardiography I will omit because otherwise this is again is a very lengthy topic. If you allow me, I can just go to the summary of this. What is there in the for the echocardiography? So broadly, what is happening in PPHN? Yeah, sorry, you were saying something.
No, sir. You
Okay.
can continue.
What is happening in PPHN is the blood normally goes from the RV into the right pulmonary artery and left pulmonary artery. But let's say there is a constriction there. Let's say there is a constriction. I have made the constriction here, although the constriction is normally in the peripheries. Okay. So the blood cannot go in this direction. So a little bit of blood will go back from the RV to the RA, and that will be demonstrated as a TR, that is tricuspid regurgitation. Similarly, because the RV becomes the dominant ventricle and it's failing, it will deviate the septum towards the left side. Okay. And then the right ventricular output decreases, and eventually the LV also fails and left ventricular output also decreases. And there is a shunting because the blood is going from here, the RA gets overloaded, and there is a shunting through the PFO in this direction from the right to left. Remember, in PPHN, there is a right to left shunting which is mandatory, which should be discernible and which should be demonstrated by echocardiography. And then across the ductus, this one is the PDA. So there is a bidirectional or the right to left shunting. What is happening is that the blood is going from here, but here the pressure is very much increased, so it cannot go into the lungs, or less of it can go to the lungs. So the duct becomes a Popov, and there is a blood which goes through the duct in this direction, from the pulmonary artery to the red colored aorta. So remember, never ever close the PDA in the presence of PPHN. Why? Because this duct is offloading your right ventricle. Because the blood cannot go into the lungs because of the increased pressure, but this PDA is offloading the RV. It is acting as a pop-off valve because the blood is going in this direction. And it is sustaining the systemic circulation, be it the kidneys, be it the intestine. Although I will agree that the oxygenated and deoxygenated blood mixes, but it is at somehow sustaining the systemic circulation. If you close it, the complete disaster will happen because the RV will eventually fail. The LV has already failed, and the systemic circulation, the child collapsed. Also, whenever you are doing the pulmonary vasodilator therapy, means you are dilating the pulmonary vasculature. Remember that your systemic blood pressure should be appropriate. The systemic blood pressure should be appropriate, and you are giving appropriate inotropes. So this is the hemodynamic profile, and I will skip it. Okay, this is important. This is important slide. So understanding phenotype is most important. What is the phenotype? So this is the normal one. In the normal one, the LV is the dominant one. Okay, and LA as compared to RA is dominant one. So blood is shunting in this direction, and through the PDA also, if present, it is in this direction. In mild moderate PPHN, what happens is there is a bidirectional shunting because blood goes here also, like this also. Similarly, here also bidirectional shunting. So there is a bidirectional shunt at the PDA. When the severity increases, this septum goes deviated because RV dysfunction is there. Septum goes deviated towards the left side. The shunting is pure right to left, pure right to left at both angles, PFO also, PDA also. And if you see the LV, the preload is less. And then there is a severe PPHN when this LV dysfunction also starts. Then what happens is that the LA gets overloaded. The LA gets overloaded, and when the LA is overloaded, then the shunting is in this direction. And there is a pulmonary venous hypertension. Why we need to understand this is, let's say I give pulmonary vasodilator here. There is already a pulmonary venous hypertension. So if I give pulmonary vasodilator, so lungs are flooded with blood. If I give pulmonary vasodilator and the pulmonary vasculature relaxes, the lungs get more flooded with blood. So in this step, unless and until I will take care of the LV dysfunction first, LV function first, I will get my LV better, and then I will start then I will start pulmonary vasodilator like nitric oxide, or I will do both the things simultaneously, but I will not do along this thing. So if you see, echocardiography can tell you which way the shunting is, which ventricle is bigger, what is the output, whether there is a LV dysfunction or not. So echocardiography is very helpful. Without the help of echocardiography, it is difficult to manage a baby with PPHN. Okay, so these are the few answers one should get from the cardiologist, that PDA, which shunting is there, bidirectional shunting or right to left shunting, PFO, which shunting is there, what is the septal position, LV function, RV dysfunction, RV systolic pressure estimate, confirm the normal anatomy and the pulmonary veins. I will just skip this for the benefit of the time, because this in itself is a very, very huge topic and a long talk. So I'm leaving the PPH, or the echocardiography part. Now about the management of PPHN. So remember, this first limb is very, very important. Let's say the cardiologist tells you PPHN. Do not shift or do not go and start the inhaled nitric oxide immediately. First, go for supportive treatment. Optimize the ventilation. As I was telling you, in that triad, the ventilation is the key important step. So let's say it's a case of MAS or RDS. Give surfactant. Maybe after surfactant, your PPHN resolves, right? Then remember to keep CO2 and oxygen target not too high, not too low. So there was a time when we say that initiate respiratory alkalosis and bring the PCO2 low to 35 to 45. But now the time has gone, 55 to 60 or 45 to 60 CO2 we keep. Similarly, oxygen briefly hypoxia, no hyper 50 to 80 of PaO2 is good. Minimal handling is the key. sedation and analgesia, no routine paralysis. Routine paralysis has led to increased mortality in babies with PPHN. Consider surfactant, correct the acidosis, but do not give bicarb for correcting acidosis. It may lead to sensory neural deafness also. The bicarbonate may worsen the intracellular acidosis. So do not give bicarb. Try to correct the underlying cause. Underlying reason is the correction in the ventilation and the perfusion, and avoid routine paralysis. Pulmonary vasodilator, I showed you in that table, INO, sildenafil. Then inhaled prostacyclin, milrinone. PGE1 is to keep the duct patent. I told you never ever close the duct. Keep it patent. Bosentan and nitroglycerin. Nitroglycerin we don't use routinely, but yes, bosentan sometimes. Then vasopressors. Now the major question is that which inotrope to give. So what I will suggest is avoid those inotropes which can lead to pulmonary vasoconstriction. What are those inotropes? Norepinephrine, vasopressin. Milrinone is a very beautiful because milrinone is an inodilator. It improves the LV function also. It takes away the LV dysfunction. It is a pulmonary vasodilator. But the problem with milrinone is that sometimes the blood pressure drops too fast. So give it in association with the norepinephrine so that the vascular tone is maintained and the blood pressure does not fall. Sometimes epinephrine, hydrocort you can use, and levosimendan is the newer drug which we don't have too much experience in using it, but we use vasopressin very much often. So the same thing which I explained you, cover the eyes, cover the ear, give surfactant, try to optimize the ventilation, conventional ventilation. These are the settings, and you should know when to switch to HFO. What are the initial settings of HFO? Do not target too much. pH of 7.25 is okay. Less than 3 is okay. You more than 1 is PCO2 45 to 60, PO2 50 to 80, 8 to 9 rib expansion. Blood pressure is 35 is okay. 35, 45. Gone are the days. Previously, we used to chase the systemic blood pressure 60, 70, 75, 80. So gone are those days. So I think it's already 9:38. I will just take 2-3 minutes and I will summarize this because otherwise this is very, very long thing. Bicarbonate, I told you it may worsen the intracellular acidosis. So do not give it. Supportive management, alkali infusion, I told you do not give it. Blood gas parameters, I have told you. Pulmonary vasodilator. So as I was telling you, PGI2 will increase the CMP. Milrinone will prevent the degradation of CMP. So these two will work synonymously. INO, sildenafil, bosentan. So remember those. INO protocol also you can remember. Rule of 20-20-20. When do you start? O oxygenation index more than 20. OI was MAP into FiO2 by PO2. When it is more than 20, start at a dose of 20 ppm. And how do we say that whether it's responsive or not? Is the initial response of PO2 divided by FiO2 of 20. That what does it mean? That at the same level of FiO2, PO2 before starting was 50 and after starting nitric oxide it comes to 70. That means it is NO responsive. There is no major monitoring is needed when we are using at a dose of 20. How when we wean, when the FiO2 becomes less than 60, you start weaning it, PO2 is more than 60 and it remains for at least 60 minutes. How do we wean? From 20, we go to 15, every 4 hourly, then 10, then 5. At 5, then we go slow, every 4 hourly, 4, 3, 2, 1. Why? Because if we stop abruptly after 5, it may lead to rebound pulmonary hypertension. Study has shown that babies with CDH, it does not respond because there is a pulmonary vascular hypoplasia, which I explained. Which group it responds better? MAS, pneumonia, PPHN, RDS. NO and HFO, they are very much synergistic, right? When we give both of them, the blue is both of them, you can say that response is so good. Why? Because HFO leads to uniform distribution of the INO. I think sildenafil can be used. It's the poor man nitric oxide. You can use it. Can we combine? This is the systematic review. Time does not allow me to go so much of this. So what I will do is remember these drugs and you can look at the book and you can look at the dosage of these drugs. Nitric oxide, I have told you. In sildenafil, do not give the loading dose because it may sometimes lead to hypotension. Similarly, in milrinone also, do not give the loading dose, just give as a continuous infusion. The inotropes I have told you that what is our target is, okay, so this is the good lines. So if you are dealing with hypoxemia, INO will work. If we are dealing with hypotension, you can give epinephrine, hydrocortisone, vasopressin. Cardiac dysfunction is there, milrinone will be very good, and prostin. And sometimes when we are dealing in India, a case of sepsis with PPHN, we have to give almost everything to look for the baby, but it should be echo guided and it should be easy. So, okay. When to think of ECMO? Why more than 40? We should go for ECMO. So I think thank you. I have to cut down because this is a lengthy topic. And sorry for that, but thank you very much. And I am happy to take questions.
Thank you, sir, for such a wonderful talk. I'll request residents if they have any questions. You can ask by unmuting yourself.
Please ask question, even if the questions will be basic, no matter. Basic means outside of this purview. Sometimes the talk is little hi-fi. I mean, looks hi-fi to the initial postgraduate. So don't feel like that. And you can ask as many questions.
You can also write in chat if you're not keeping the video on.
No problems.
Thank you, sir. Thanks for such a
Thank you.
wonderful lecture.
Thank you,
So,
Dr. Lata. With you, if
especially
you give
the
me, yeah, sorry.
yes, sir. Yes, yes. What do you say? Want to say? Please, sir.
No, nothing. Please first you complete. Yeah. Okay,
Yes,
somebody has
sir.
asked, how can we guess LV dysfunction? So the echocardiography is a very good way of suggesting you LV dysfunction. In the left ventricular output will be decreased. Now, suppose you don't have a echocardiography, the clinical signs are if the pulse volume will be low and if your systolic systemic blood pressure is dropping, you can think of LV dysfunction. Did I answer the question?
Yes.
Okay. Okay, Dr. Lata, sorry, you were saying something.
No, nothing, sir. Your that sketch thing was very good. That was you're using pens during lecture. That is a good thing.
Thank you.
So
Somebody
one
has
more
written.
question.
Yeah.
One more
Any other
question.
reason to keep the PD open except in cases of LV dysfunction? Yes. So sometimes to keep the PD open. So if you feel that it's a very severe case of PPHN, your TR jet is very high, and there are few other echocardiographic parameter. The RV, the septum is quite deviated towards the left side, and majority of the shunting through the PDA is right to left. Never ever close it. You just keep it open so that the RV, it offloads the RV. It prevents the RV dysfunction, not the LV dysfunction. It prevents the RV dysfunction. So once your PPHN will improve, then usually the PD automatically closes. But sometimes what happens is that the baby is not maintaining on INO, sildenafil, prostacyclin inhaled. Then sometimes we give PG even deliberately to keep the ductus open because the ductus has started closing. Then those are the babies. Sometimes after 2 weeks, our PPHN subsides, but then the PDA starts getting troubling us because of the left to right shunt. So those are little tricky babies. But the message is that you have to look for the ductus on a daily basis and look for the other parameters also. Do not close the ductus in case of RV dysfunction, or if there is right to left shunting or bidirectional shunting across the ductus. So thank you so much, Dr. Lata, and everybody, Dr. Prashant, and I just, right. So thank you so much, everybody, Dr. Sanghavi, ma'am, and I have to go somewhere. So with your permission, can I leave the meeting?
Yes, sir. Sure, sir.
Yes.
Sure.
Yes.
Thank you very much.
Yes.
Thank you, sir.
It was a pleasure to be here on this platform. Thank you.
Yes, sir. Thank you, sir.
Thank you.
So now we are going on to next session of interesting quiz, and I'll hand over that to Prashant sir. Prashant sir, please.
Yeah,
The
thank
stage
you
is
so
all
much.
yours.
And I've already posted the quiz link in the Zoom chat box. And before we begin, we do have Abhishek Kalyankar from Zorvia who is sponsoring the quiz
Thank you,
amount. So
sir.
I request him to say in a minute something.
Yes, sir. Thank you, sir. Thank you very much. And on behalf of Zorvia Healthcare, I sincerely thank you for giving us this opportunity to be associated with such a wonderful academic initiative. Personally, sir, I would like to thank Dr. Yogesh Parikh, Dr. Prashant Kariya, sir, and Dr. Sanghavi, ma'am, for extending the support, for allowing us to be a part of this esteemed platform. At Zorbia, we always believed and we have always supported as far as all educational activities, academic activities are concerned, and we will continue to support such kind of activities in near future. And e-Gurukul, I would say, it plays a vital role in enhancing patient outcomes and basically improving patient outcomes. Once again, we extend our sincere thanks, okay, to the entire team of e-Gurukul, and we look forward for many more such collaborations in near future. Thank you, sir. Thank you, ma'am, for giving us this opportunity.
Yeah. So thank you so much. And thank you once again to Team AOP Gujarat led by Jhankhana ma'am and Nehal ben. And under the guidance of Baldev sir, Yogesh bhai, Sandeep bhai, and under the planning of Lata Ja, we are having this quiz every month, once at the fourth Thursday. So this is those who have already know. I've posted a link in the Zoom. You can just click on it, or you can click on kahoot.it and enter the game pin 1139355. Almost 50 people have joined, so I'm just starting. Anytime if you want to join, Lata ma'am, please post the link in the WhatsApp group as well as in chat so that people can join, but we can start. So those who are joining for the first time, I'm just saying this. This is a quiz in which you will be seeing the questions, and those who give answers fast will win. Fast and true. So say for example, this is a question: what is the status of Trump and Iran war? A ceasefire, a tension, a talks. Let's see what happens tomorrow. So this type of question will come and you will have to answer it. And once the timer ends, the marks will be there, because this is a poll question. There is no marks, but 50 people have answered and everybody is saying the different things. So accordingly, we will be judging. Same way, one more question for a baby crying loudly. What can be the cause? A hunger cry. Mummy भूख लगी, mummy खाना दो. Evening colic. तड़प तड़प के इस दिल से आह निकलने लगी. Sleepy baby. सो गया ये जहां सो गया आसमां. And wet nappy. भीगा diaper मेरा. So this type of questions will be there and you have to answer it. I think people are answering. 60 people have already answered, and that means we are ready for the quiz. All the best to everybody. Remember, it's most important that we participate and we have a fun. That is most important thing. But top 11 winners will be getting the prizes worth 15,000 rupees. So starting the quiz, all the best to everybody. What is the normal respiratory rate in newborns? 30 to 40 per minute, 40 to 60 per minute, 60 to 80 per minute, 20 to 30 per minute. In 5 seconds, we are having 60 answers, so it's a good thing. Expecting the others to answer. And the correct answer is given by almost all, that is 40 to 60 per minute, and that is correct answer. And the fastest answer was given by CM, followed by V and then Shivani. Next, what is the definition of hypothermia in newborns? Less than 36.5, less than 35.5, less than 37, less than 36. Jhankhana, it's good to see people are answering. I mean, 67 people have answered in 10 seconds only.
Yes, 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 yes.
So, I mean, the 20-second timer is working.
Yes.
Yeah. So, majority are right. That is less than 36.5. We consider that as a hypothermia. See, mild hypothermia or a cold stress will be 36 to 36.5. Between 32 to 36, it will be moderate, and less than 32 will be a severe hypothermia, and that can cause a problem. So that is most important thing. And the leaderboard changes. The Y is coming up, followed by JK, hit. By when does the weight of a newborn doubles? 5 months, 6 months, 4 months, or 3 months? And again, in 5 seconds, 69 answers.
Oh.
So this is most important. Whenever we are dealing with a newborn child, we must know when the weight doubles and triples. As such, we say that the weight gain pattern is such correct. 5 months is the correct answer and given by the majority. Initially, there will be a weight loss, but then in term babies, 20 to 30 gram per day will be a weight gain, and by 5 months it will double. So MPV is leading, followed by the EVAN and ZES. So that is most important. Okay. Coming to the next question. Which of the following is a risk factor for retinopathy of prematurity? Hypoxia, normoxia, bradycardia, or hyperoxia? Now, this is most important because in NICU, when you are using oxygen, that is should be considered as a drug, and hyperoxia, that is one of the things which must be avoided. If the child is maintaining saturation more than 93, no need to increase the oxygen, and no need of having an oxygen saturation of 100%. That is most important. Try to treat oxygen as a drug, write in order that the oxygen to be given at 2 liters per minute and via which route, whether you are giving through a nasal cannula or through a CPAP or anything. But then the titrated oxygen should be given. That is most important. And MPV, Ivan, Zez are still leading. 6 participants are having a streak of 3. A neonatal hypopolycythemia is defined as a hematocrit level more than 65%, more than 60%, more than 55%, more than 70%. Again, in 10 seconds, we are having 71 answers. I'm glad that people are replying fast. And we have kept initial 10 questions for the undergraduate and postgraduate levels only. 65, more than 65 is the correct answer, so that you people can enjoy initial parts. Zaz is the new entry, followed by a Vishal. Okay, next question. Where is the PDA murmur best heard? This is most important. A right sternal border, a left upper sternal border, apex, or a back. Because many times now we just say that this is a murmur which has been heard. Initially, Baldev sir is there in the meeting, and I know sir used to teach us sight, the intensity, everything. But the left upper sternal border pan-systolic murmur, if it is heard, unless proved otherwise, it is continuous machinery murmur if it is there, and it is PDA. So that has to be known by everybody. Okay. What is the most common cause of non-bilious neonatal vomiting? That is most important. A GER, NEC, pyloric stenosis, or atresia. Again, 74 answers in 10 seconds. And next 10 seconds, we will be actually saying what is the cause of non-bilious neonatal vomiting. See, non-bilious is GER. If it is bilious, it is pathological, mainly NEC, stenosis, or atresia. That is most important. So correct. There is a streak of MPV is still at the top, followed by a ZAZ. What is the difference between caput succedaneum and kephalhematoma? Caput crosses sutures, kephalhematoma crosses sutures, both crosses sutures, and neither crosses suture. Now, this is just an important thing by which we can actually know 77 answers are still there. And we have to remember that, yes, the correct answer is caput is crossing the sutures because it is not below the periosteum. The scalp is having 5 layers: skin, connective tissue, and the last layer is the periosteum. And if below that there is collection, that is actually a kephalhematoma, that will not cross the suture line, but the caput is the swelling in the layers of the scalp, so that will cross the suture lines. Okay, so MPV is still leading. N is the new entry. Remember, those who are leading, you are supposed to take the screenshot at the end of a quiz and send it to either a mobile number or an email to claim your prizes. So the first 10 questions are over. Coming to the next set of 10 questions, a double point question. A neonatal chest X-ray which you are going to see, I'm telling you it is showing hyperinflation, a prominent vascular markings and fluid in the fissure. What is the diagnosis? A pneumonia, a TTN, RDS or MAS? So when it is hyperinflation with prominent vascular marking, great. I mean, out of 77, almost all are right. It's a TTN. If it was a RDS, a granular pattern or a decreased lung fluid will be there. So good answers by everybody. RIM is the new entry which is there. Which of the following defines early onset sepsis? This was last time discussed. Infection after 7 days, infection after discharge, infection within 72 hours, and hospital acquired infections. So in 10 seconds, 77 people again answering. By this way of teaching, we actually know what is early onset sepsis. So yes, we all know, and the correct answer is given by almost, I mean 100% correct answer. 79 answers are there and all are correct. That infection within 72 hours is early onset. Between 72 to 7 days will be a late onset, and that is most important. But great that everybody is playing and playing with a good knowledge. So good. Next, what is considered the gold standard for diagnosing neonatal sepsis? Whether it is CRP, CBC, blood culture, or procalcitonin. Over here, once all answers come, I like to say that many a times for diagnosing neonatal sepsis, we are using only one parameter. Only a single CRP or a single procalcitonin is of no use. A serial measurements will be there, and the gold standard always remains is a blood culture and given correct answers. Which maternal factor is triggered for neonatal infection screening? If it is there, then you will go for the neonatal infection screening. Polyhydramnios, maternal hypotension, maternal anemia, or fever more than or equal to 38 degrees Celsius.
Yes.
Yeah, again 79 answers in 10 seconds, and everybody I think should be right in this. And yes, it is fever more than or equal to 38 degrees Celsius in mother. Most importantly, it can be early signs of chorioamnionitis, and that should be checked. Again, from the infection session, what does a negative sepsis screen with clinical stability at 36 to 48 hours suggest? Repeat cultures, need for lumbar puncture, stopping antibiotics, and escalate antibiotics. Now, this is most important that while you are doing this septic screen, your treatment part should be actually be changing. If it is negative, then you have to stop the antibiotics. De-escalation, you have to trust your lab reports and clinical condition also. So in that case, stopping antibiotics and having antibiotic stewardship will be helping us. Okay, coming to the next question. Which of the following is a common pitfall in neonatal sepsis screening? Over-reliance on CRP, using serial CRP, integrating findings, and culture before antibiotics. Now, I'm asked slightly tricky question. What is the pitfall in neonatal sepsis screening? That means when you are doing serial CRP, that is fine. You are integrating the findings lab with the clinical. You are doing culture before the antibiotics. That is fine. But only reliance on one CRP is the wrong thing and should not be done. MPV is still leading the board. Now some different questions will double points. Which of the following acts as a natural anticoagulant? That is factor 8, factor 12, factor 7, and protein C. For this question, I have given 30 seconds, but in 10 seconds, we are having 77 answers. once we have almost all answers, then we can say this. The natural anticoagulant is protein C, and correctly said by almost 70% people, and still the leaderboard's MPV is still at the top. Okay. The double point question. What is the effect of oxytocin during labor on neonatal coagulation? It increases the factor 7, no effect, decreases the factor 7, and increases the fibrinogen. Oxytocin is the hormone which is secreted during the labor, and it is having many advantages, and one of them is it decreases the factor 7 level. Okay, what effect does a blood sample from a hyperonized line have? When you take that, it will increase the APTT, decrease the PT, no change, and decrease the APTT.
Increase APTT. Oh,
yeah. Yeah, ma'am, you are right. But your mic is on, so people will listen to you. It is increase the APTT. So it's a correct answer, ma'am. Okay. So avoid hyperonized sample. A double point question. What is the acceptable electrode impedance for an EEG? 10 to 20, less than 30, more than 20, less than 10. Again, same 70 answers in 10 seconds, and this is becoming interesting. People know the answers very fast, and majority, for this was a difficult question, that electrode impedance of less than 10 is considered as a acceptable range, and that was said by only 16 people. Next question, double points. What is the recommended thing for a postnatal renal ultrasound in case of it is missing hydronephrosis after 48 hours, after 7 days, within 24 hours, or within 48 hours? So the postnatal renal ultrasound should be done after 48 hours, even though I said it is missing. The correct answer is given by many, because initial part there can be a oliguria and that can cause a problem. So in that cases, we have to do after 48 hours. Good. Again, a double point question. What is the mechanism of meconium passage during hypoxia? It is a mechanical pressure, a parasympathetic activation, a hormonal suppression, or a sympathetic stimulation. So the hypoxia will actually lead to the activation of the parasympathetic system, and there will be a meconium passage, which is correct answer and given almost by a majority of you. So correct answer. Fine. According to 2025 neonatal resuscitation guidelines, pre-resuscitation team briefing, what is emphasized? That is, you have to communicate and plan, you have to delay briefing, you have to focus on equipment, or you have to assigning roles after delivery. So this was the last panel discussion in which we had a nice discussion on neonatal resuscitation, which says that for a good resuscitation, or for NRP practice says, a communication and planning is the thing which has to be done. The briefing has to be there. Roles should be assigned before the delivery, and focusing on equipment should be done. But then most important is communication and planning. That is most important. So Shivani is back in the game, top 5. Next, what is recommended for maintaining normothermia in a preterm infants less than 34 weeks? Again, this was said in the last presentation that you have to use plastic wraps and warmers, immediate bathing after birth, keeping the baby uncovered, and delayed drying. So in less than 34 weeks, preterm babies, this is the recommendation in 2025 guidelines, which says that we have to use plastic wrap and warmers, which is most important. Immediate bathing after birth has to be condemned. Keeping the baby uncovered should not be done, and delayed drying is never a rule. It has to be a immediate drying. Okay. Next question for a double point. What is the preferred method for rapid and accurate heart rate assessment in neonates in 2025 guidelines? And that is most important. Observation of chest movement, ECG monitoring, auscultation alone, or palpation of umbilical pulse. Now, in 2022, before that 2018, I mean, there were many changes which were happening, and this 2025 new change definitely says that you have to apply the monitors immediately and relying on ECG monitoring. And that's why we say you have to attend the neonatal, Gurukul Pathshala, so that you know what are the changes, and the questions are coming from that only, that ECG monitoring is the important thing which has to be done. Okay. Coming to 26th question, which is again a double point question. What is the updated role of supraglottic airway, that is SGLMA, in neonatal resuscitation? That is not recommended, only after compressions, alternative to intubation, and only in term infants. This was also said in last panel discussion that a supraglottic airway, that is LMA, should be used as an alternative to intubation because it is very easy, and that has to be used, can be used anytime, and doesn't require good knowledge. Only thing is you have to hold it properly, and if you use it 1 or 2 times, it is very easy to use. Okay. Coming to the 27th question, now I think I will be having around 4 or 5 questions only. How should blood glucose be managed after neonatal resuscitation? That you have to ignore unless symptoms appear. You have to maintain strict hyperglycemia. You can give glucose after 24 hours, and you have to maintain normal levels. Now, this is also a change, and in a panel discussion, it was said clearly that after neonatal resuscitation, most important is to maintain the normal glucose levels so that it helps further in management of a child. Okay. What is the initial IV epinephrine dose in neonatal resuscitation? Again, this is a new change which is there. 0.02 milligram per kg, 0.1 milligram per kg, 0.01 milligram per kg, and 0.05 milligram per kg. So till now, what we have learned or what we were doing was simple thing that we start with a lower dose of 0.01 milligram per kg and then increase, but 2025 says you have to directly start with 0.02 milligram per kg of adrenaline. That is most important thing. Coming to last 3 questions, and all the best to everybody. Siddharth, Reem, and VI, everything is there. All the best again. Double point questions. An occipital encephalocele combined with cystic kidneys suggest which condition, and that is most important, whether it is VHL, whether it is Joubert, whether it is Meckel syndrome, or what is Bardet-Biedl syndrome. So good that 80 people have said. Yeah, so 27 people have said a correct thing. Now this is something at end we are keeping slightly tougher questions, but just to tell you something, this Meckel syndrome is a rare genetic syndrome which is belonging to a group of ciliopathies which is there, and in this there is a classic triad in form of a brain abnormalities, as in this case we do have occipital encephalocele which is most common, then kidney problems, that is again a polycystic kidney, and can someone write in chat what is the third thing? Lata ma'am or Jhankhana ma'am, if somebody is writing, what is the third thing? If we have some answer. Okay, just to save the time, it is. What?
No answers till now.
Okay. Yeah, so it is.
Diabetic, actually.
Yeah, very good. Somebody said right.
Yeah,
It is
yeah.
polydactyly. It's a triad.
And diverticulum.
Yeah, and a diverticulum. Yeah. I mean, there will be other things, but the triad of this, a polycystic kidney, polydactyly, and the occipital encephalocele, and your diagnosis is confirmed. Okay. Coming to the next question. Last two questions. At what gestational age does the hypothalamic pituitary axis matures? 24 weeks, 16 weeks, 12 weeks, 18 to 20 weeks. So this is most important, that during this weeks, this hypothalamic pituitary axis will actually mature, and the correct answer given by many, that is 18 to 20 weeks. The top is Pooja and having a streak with 12 correct answers in a row, followed by a Siddharth and then MPV. A last question, all the best, double points. What finding supports a diagnosis of growth hormone deficiency? IGF-1 low, growth hormone less than 5 nanogram per ml, a pituitary enlargement, or a high growth hormone? Almost 77 answered swiftly with 81 answers. Few are right that it is growth hormone less than 5. See, usually the IGF-1 low can be there, but growth hormone deficiency is diagnostic by less than 5 nanogram per ml. And by the time the result come, just a quick feedback from all of you. How was the quiz? Very easy, moderate, or hard? Now, those who are playing, please be on a screen. You have to send screenshot along with your name, GPay number, to a mobile number or email that will help us to transfer the money. And this money will be transferred usually within a week. And this time the quiz is moderate. So thank you so much to everyone. And coming to the podium, the first third rank is of MPV. Please, if you can write down your name. Siddharth is second, and top is Pooja is at the top. And I'll be showing you on screen the other 10 people who are actually getting the prizes. Just give me a minute. We are just showing you online only. Please. Oh, so sorry. Yeah. Session summary. Yeah. So view full report. I hope my screen is visible.
Yes. Yeah, it's
Yeah.
visible.
And this quiz was played by 138 members.
Oh.
And these are the names of the winners. I'm just taking a screenshot so that we can have it. First is Pooja, 93% correct answers. Second is Siddharth, 86% correct answers. Third is MPV, 90%. Fourth is R, that is Ramya, 79%. Then VI, then Asfia, then Eddie Bravo Doc. If I remember, Eddie Bravo is playing for the third continuous time and winning this.
Yeah.
Sona, Rim, and DP, and one more will be getting the prize, that is JK. So I'm just taking the screenshot of this, and I'll be posting this in a group also. And you are requested again that you have to send the screenshot to our numbers and email account. Thank you so much. If anybody wants to say anything, Jhankhana ma'am, yeah, open to everybody. Yeah.
It's excellent. Lata, what of things?
Yeah. No. It was a really nice. It was a very good session with such a good expert talk and such a wonderful quiz with everyone so much active at 10:25 p.m. at night. So thank you, Jhankhana ma'am, for being there for support. Thank you, Baldev sir. Thank you, Sandeep sir. All the respected faculties who are there here. Of course, last but not least, Prashant Bhai, who has made such a wonderful quiz for today. And all the delegates who have participated, all the persons who have contributed. Thanks to all of them, and hope we'll have more wonderful sessions in coming weeks. Thank you, everyone, and good night.
Thank you. Good night to everybody. Thank you very much.
Sandeep
Good
bhai.
night.
Good night. કેમ છો?
Good night.
Excellent, Prashant.
Thank you, Sandeep bhai.
Excellent.
મારો permanent secretary.
Yeah. So thank you.
Okay. Thank you very much.
Okay, chalo. Okay. Bye bye.
Thank you.
Good night. Good night.
Good night.
Good night, everyone.
Good night.
Good night.